here is her pain. Glute, down the back of the leg, around the outside of the thigh. So there's her symptoms, okay? So when I saw her on the screen, what I saw her fail is pronation control on this side and weight bearing on this side. This side was pretty good. This side, we also have an issue. She has shoulder pain and limited range of motion functional movement with flexion, extension, flexion, abduction, internal rotation. Also, C-spine, we have an issue. So wait a second. Are we going to assess and treat all of these in the first visit in an eval in less than a half an hour? And also be able to circle back and redo her functional screen and do patient education and do home exercise program? Yes, we are. Here's how easy it is. Okay, so put her on the table. I'm going to check the uninvolved leg first because that's going to tell me what her normal should be, okay? So I want her to feel what things should feel like. I don't want to put her in a painful position and have her fail, and now all of a sudden she's focused on pain. I want to take pain off of the table, okay? So we're going to assess here. So I'm going to assess glute max, glute med, vastus lateralis, rectus fem, all this stuff over here. Hopefully my pen won't give out. Okay, so I'm going to assess that, and she passes, no problem. She does report low back pain when I do those things. But when I say, does that feel strong or weak? She says, yeah, that feels pretty strong. Now I jump over here and test the same muscles, and guess what? Fails glute med, fails glute min, fails vastus lateralis, fails glute max, fails semitendinosus, fails membranosus, fails soleus, fails tibia anterior, fails all this stuff over there. Fails, fails, fails. So what I'm doing as I go through, so the first thing she failed was glute med. She fails, increases pain, shoots pain down her leg, can't stop me, totally weak. I treat it, I come back and I reassess it, she can stop me. She has a fraction of the pain that she had before going down her leg. She's like, what happened? I said, hold on, I'm not gonna. So up until now, I haven't told her anything that I'm going to do because I don't want to bias her and tell her, I'm gonna put you in positions and you're gonna feel weak and painful and I'm gonna flip the switch and you're gonna feel strong and no pain. I'm not going to bias her. I'm going to treat it and let her understand that now this side feels like this side and she has no pain, even though I did nothing with her sciatic nerve or her low back, okay? So I'm going through one by one. So glute med first, glute min, then I go to vastus lateralis, then I probably went to rectus fem, and I'm going and she fails, I treat, I retest, she passes. So as I do this, I get through about 3 muscles and she's like, seriously, what is going on? So that's when I take her through patient education and explain that the muscles that are failing are inhibited, which is why she's trying to compensate, which is why she has pain shooting down her leg. And she can't stop me because you can't overcompensate for neuromuscular inhibition when I put you in a position where one muscle has to do the overwhelming majority of the work. So that's what's going on. Now she's like, oh my God, that makes total sense. And I don't have to talk about pain and sciatica and herniated discs and MRIs and all the crap that conventional PT will tell you need to talk about because you don't, okay? So we get through that. Now when I get to glute max, before I flip her over to assess and treat glute max, I assess lat and lat. She passes, she fails. This reproduces low back pain. What do you know? So when I flip her over and work on glute max, I also work on lat. I flip her back over, retest lat, that passes. So now I've gone from lower body, I've done all of this stuff. Now I'm gonna go do this stuff. So I go through scapular stabilizers, upper trap, middle trap, lower trap, she fails. Delts, she fails. That gets me up into C-spine. So I get to surfaces multifidus, SCM, upper trap again, fail, fail, fail. Turn those on, pass, pass, pass. Now she has full passive range of motion, full passive range of motion, normal strength, normal facilitation. Come back down, get down to here, get to the anterior soleus, skip back up, and we get to pyramidalis, because what does pyramidalis do? Pulls on linea alba to keep the abs facilitated and tight so we don't put pressure and overuse the lumbar extensors and the glute max, which she already had problems with. So now that we've got abs and we also got transverse abdominis kicked in, now I can get her off the table. We redo her screen. She has full toe touch, full extension, full rotation, no pain. Full cervical extension, right rotation, no pain. Full shoulder range of motion, no pain. And now I'm going to go through and give her a home exercise program. Now, I'm only going to give her home exercises for what we did below here. So I'm not going to give her anything for C-spine and shoulder yet. I want her to really focus on this and get this hammered home. She's coming back in 3 days already, so we'll get that stuff later. So I give her a home exercise program that is lunge walk with the twist, crossover walk with the squat, isometrics for pyramidalis, glute max, rectus fem or quads, hamstrings, and total body weight or full depth body weight squats. She's going to do those 4 to 5 times a day, every day, and she's going to get better. So when she comes back, now this stuff is going to work. We're going to do a fraction of what we did on the first visit. On the second visit, now we can focus on that. So remember in the video, I did her eval, gave her all this stuff. She came back to see the other therapist that's working here. I didn't see her for her 2 follow-up visits. I caught her walking out of her second follow-up visit, talking about how fantastic she felt, how she had no sciatica after the first visit. Now her shoulder feels fantastic. Now she's going up to the front desk to schedule her husband and also a friend she needs a card for so she can refer them. So that's how business works. That's how we market. We don't spend money on marketing. We educate our patients. We let them go talk about us and they bring us more patients. So now, if you remember from the video, the other therapist that she's seeing is a PTA. She's not even a doctor of physical therapy. Does the patient care? No. Does she care that the other therapist isn't board certified in anything? No. Does she care that the other therapist doesn't have 25 years of experience like I do? No. Because the other therapist, the PTA, did the exact same thing, exact same thought process, exact same treatment strategy, gave her exercises to do at home for now upper body, C-spine, with the same thought processes that I did. So she did the exact same thing that I did, gets the exact same results, and that's all the patient cares about. So this is a red hot, burning, constant sciatica patient that was better after 1 visit. I did absolutely nothing with her sciatic nerve. I did nothing with her lumbar spine. I gave her no stretches. I told her to stop stretching, stop icing, stop heating, get up, be active, increase your activity level, go back to doing exercise after the first visit and do the exercises that I gave you 4 to 5 times a day. And those exercises should take somewhere between 5 and 10 minutes, which is one of the reasons why she's going to be compliant. So patients are compliant with home exercises when they A, make sense, when they're easy to do, they're convenient, they fit into their day, and they work. So every time she did her home exercise program, I gave her a test. Bend over, touch your toes, rotate your trunk. If that feels better, then you're doing them correctly, which she did every time. And she said, yep, every time I did them, I felt better. That's how you get patients to do home exercises. Okay, so when your patients are non-compliant with home exercises, that means your home exercises were the wrong home exercises. They were probably stretches, which made them worse. They're probably corrective, which made them worse. So that's why they don't do them. Patients are non-compliant with things that make them worse. Stop giving them things that make them worse. Stop thinking in the broken medical model and think like this. So after we got done with her treatment, we redid the functional screen. I gave her home exercise program, reinforced the patient education as to what we did. From the time she walked in to the time she walked out was approximately 35, maybe 40 minutes to treat 3 body regions, to get results, to educate, to give her the right exercise program, and to fix probably 75% of her problem in 1 visit. Okay, so if you've got questions, post them below. If you want to learn how to do this, make sure you reach out. It's time for you to get in the shift, and I can teach you how to do this. In less than 4 months, you can change your career.